A few differences in hemorrhagic stroke. And let's recap. Ischemic stroke is caused by a blood clot. There are two types. Ischemic can be thrombotic or embolic stroke. We discussed signs and symptoms and treatment last week, which are ranging from alteplase, which is alteplase or thrombolytic therapy, to endovascular management, intra-arterial administration of alteplase as well was an option. And then we have the CEA, carotid endarterectomy or angioplasty. Now here comes hemorrhagic stroke. And then we ended last week with the 8 core measures of ischemic stroke. So what do you make sure the patient receives from admission to discharge? And make sure those 8 are documented. Now here's hemorrhagic stroke. So this is the other type of stroke. This is only 10% of the stroke cases. The bleeding here can be in any of the meninges because we have blood vessels in the 3 meningeal layers of the brain. So the most common would be intracranial, or also called intracerebral hemorrhage. Now there are 3 risk factors here, 3 common risk factors. Of course, there are others, including, let's say, you're at a party, you had too much cocaine, for instance, you sniffed a really thick line, so that can induce a rapid rise in your blood pressure, then popping a blood vessel, and then you bleed. So that's one rare cause. But the 3 most common causes are, number 1, it's caused by uncontrolled hypertension. Number 1 example, again, a rare example is, again, if someone does too much cocaine, for instance. I don't know what you on, Philip. Are you like that, like too thick or just a little? Okay, all right. Oh, yeah. So anything that will induce a sudden rise in blood pressure. So this will also include later when we get to spinal cord injury, a complication, an acute complication of spinal cord injury is called autonomic dysreflexia, which is characterized by severe hypertension. We discussed one earlier in the semester with pheochromocytoma. So that's another condition. So any condition that results in eclampsia, preeclampsia included, anything that will raise blood pressure in such a short time can induce a stroke, a hemorrhagic stroke. So that's why in every one of those cases, including hypertensive emergency, one of the nursing interventions is to monitor for perform neurologic assessment. So the neurologic assessment is because of this. So the patient with severe hypertension is at risk for hemorrhagic stroke. So therefore, your assessment includes neurologic. The more common causes of hemorrhagic stroke besides hypertension are AVMs, arteriovenous malformations. These are congenital anomalies. So let me show you a picture. So you can be born with this. This is formed in utero, and you go on living without knowing that you have it. This can occur anywhere in your body, but 2 most common sites of formation are in the brain and in the mesentery. The mesentery are the blood vessels supplying your GI tract. So these are the 2 common places these can occur. What it is it's a connection, an abnormal connection between an artery and a vein without a capillary network. Because normally arteries and veins are not connected, except when we created one, for instance, an AV fistula. So this one is how the structure is supposed to be. So the pressure from the artery is buffered by a capillary network before they form and continue on to the vein. Now, this is an AVM. So you develop normally until you're an adult, And then these things become a problem when you get older, because now we develop atherosclerosis, hypertension, then these things will pop because the pressure is so high now because we're older, and then they bleed. Okay, so this can occur again either in the brain or in the mesentery. So that's one cause of hemorrhagic stroke. The other is aneurysm. So we have two types of aneurysms. We have a fusiform aneurysm or a saccular aneurysm. Let's look at pictures. So what is an aneurysm? It is a weakening of the two inner layers of the artery. Now, the external layer is intact. So that's what we call an aneurysm. So only the two, the intima, the endothelial and the intima layer, or also sometimes the medial layer, are affected. So they're weakened. Number one risk factors are hypertension and atherosclerosis. So smoking or any other condition that leads to atherosclerosis plus hypertension will lead to the dilation of this artery. And depending on the size, will determine whether you're gonna have a stroke or not. So these typically don't have symptoms except for a headache, for instance. So this type here is called fusiform because they're circumferential. The dilation is circumferential. If it's only on one side, such as this one, it's called a saccular aneurysm. And there's also something we call a pseudoaneurysm, which is not really an aneurysm. A pseudoaneurysm is more like a hematoma. So this is a pseudoaneurysm. So it's not really involving the artery at all. It's more like a contained hematoma, meaning the patient suffered a puncture wound, such as a cardiac cath, for instance. You puncture the a large artery like the femoral artery, and then it bleeds, but then the bleeding is contained by your leg, your thigh tissue, so it doesn't bleed out. So that's what we call a false aneurysm or a pseudoaneurysm. Those don't cause a hemorrhagic stroke. So the AVMs and aneurysms are the ones that do. Hemorrhagic stroke has a higher mortality compared to ischemic because this involves bleeding. So therefore, the patient, one of two things can occur. Either the patient bleeds to death, or in this case, because it's hemorrhagic stroke, so the bleeding is intracranial. And the patient typically has a sudden uncontrolled rise in intracranial pressure. So they have literally a few minutes to get into this OR and undergo a craniotomy to relieve pressure. Otherwise, they'll die. They'll just drop dead. Please watch the video. It's a very good animation for hemorrhagic stroke. So I described already the three most common risk factors, so namely aneurysms, AVMs, and severe hypertension. Now, as far as bleeding, which layer of the meninges the bleeding is at, meaning this depends on the location of the artery involved. Now, it will not matter because regardless of the location, what will it do to the intracranial pressure? Will increase intracranial pressure. Remember, we only have three things in the skull. They should only be 80% brain tissue, 10% blood, and then 10% CSF. If you is there room for anything else? No. So if one component increases, there's no room. Something will have to be pushed out. And that usually, you agreed with me last week, what will be pushed out? The brainstem. Okay, and then once the brainstem is pushed out, we call that brainstem herniation, depending on if it's uncal, which is downward, or lateral, or both combination of lateral and downward herniation. Then that will squish the brainstem, and then your patient will just stop breathing, blood pressure drops, heart rate drops. So I described and showed you pictures of AVMs. Let's go to manifestations. So they'll share similar characteristics as with any other stroke patient. So they'll have the slurring of speech, BFAST, the same acronym. However, these patients typically undergo or sustain other manifestations not seen in ischemic stroke, especially the severe headache. What do you think is the cause of the severe headache here? The increased intracranial pressure. So some patients may sustain seizures. So they'll have seizures before they die. And then they'll go into a coma. And then depending on whether or not the patient has advanced directives, the family, the survivors will have to decide on, what to do with the patient. Especially if the patient has no chance of recovery, then so that they have a very difficult decision to make. So otherwise, the patient, we can keep anybody alive. However, that's about it. I mean, there's no brain function, but their body is alive. So again, the family, the survivors will have to make a decision on how they want to handle, or if the patient left any verbal or written wishes. Will these patients experience a TIA?
Yeah.
There's no chance for a TIA, because once the AVM, the aneurysm, or the severe hypertension ruptures a blood vessel, will there be a TIA?
No.
No, it will go into a stroke. It's a full-blown stroke at that point. So this type of stroke will not have a TIA. Only the embolic and the thrombotic ischemic strokes do. But just like any other stroke patient, the first intervention once they arrive in the ER will be what? Okay, CT scan. So we still do the same. So they arrive, stroke-like symptoms, we go straight to the CT. And once we have a hemorrhagic stroke, do we prepare alteplase?
No.
Okay, the patient will go into the OR. Okay, depending on the CT finding, if the bleeding is active, then they'll go straight to the OR. However, if it's a hematoma, meaning there's no evidence of an active bleed, meaning the vessel ruptured, usually if a vein ruptured instead of an artery, if that's what happens, then that means, is there an active bleed or is it a hematoma already? Okay, already a hematoma. So depending on the size of that hematoma, then they'll will determine whether or not the surgery will be emergent or if we can wait a while. Okay. Start with prevention first. So just like in ischemic stroke, here, what will be your prevention measures? And we do the same as with ischemic stroke. Yeah, the same thing, because remember, they have similar risk factors. However, how can you prevent an aneurysm? Can you control hypertension though? Yes, that's one way to do it. Or let's say you have frequent headaches. So this is more than usual. So therefore, do you consult a doctor and possibly get an MRI?
Yes.
Okay. So frequent headaches is I got approved. Okay, I didn't have a very good insurance. It was basic insurance. I still got approved in that was long ago, 1990s, and they approved an MRI because of it was migraine type headache. But at least it's good to know that I don't have any aneurysms or AVMs. Complications of hemorrhagic stroke. Of course, this will cause hydrocephalus. Now, let me explain why. Now, let's look at a brain right here. Let's look at one with ventricles. right here. You can see this, right? Okay, so these are the major ventricles in your brain. So what are ventricles? They are storage of your CSF. As you can see, they're distributed everywhere. So what is the purpose of cerebrospinal fluid? Why do we have CSF? Like, why do we have peritoneal fluid? Why do we have pericardial fluid? Okay, it's a shock absorber, right? So they allow for lubrication and shock absorption. So anything that moves in the body needs some lubrication. So your scrotum, your fascia, all these connective tissues, including the meninges, will contain fluid. So this is called CSF. So it's just like any other fluid in the body compartment. So this is constantly produced and drained. So let's say you have a stroke. So let's say anywhere, we put the stroke anywhere, and then we have a hematoma, correct? So we have a space occupying lesion in the form of a hematoma. So let's say it forms here. We have a hematoma here after a stroke, a hemorrhagic stroke. So what will it do to the structures, the brain structures, the ventricles? It grows here. It will push, it will box out the other brain tissues. So therefore, will the spaces retain the same shape? Will it impair the drainage of the CSF?
Yes.
Can that cause hydrocephalus?
Yes.
Yes, because now you're trapping the normal drainage pathways of the CSF. So that will compound the problem. So not just the hematoma, but then as a result, we call these now secondary injuries. Okay, so in brain injury, we'll cover this again when we get to head injuries or brain injuries later. It'll be the same in stroke, because once you have a space occupying lesion of any sort, whether that's a tumor, a hematoma, whatever is occupying space in the brain, it will cause up to 6 secondary injuries. So you've heard of concussion protocols, correct? Have you, in professional sports, they have concussion. Let's say, yeah, football or basketball players get hit on the head. What is done? Do they continue playing?
No.
For how long? For at least 2 days, yes, and correct. They won't get back on the field. They can't be allowed to play unless they are cleared by the physician. And where are they sent automatically after the injury? Okay, to the hospital for a CAT scan or an MRI. So why the restriction for at least 48 hours or longer? What are we trying to? We're trying to see whether or not the patient develops any of the 6 secondary injuries, because the primary injury, yes, we'll see them at the time of the injury. Okay, you'll see the bruising, the laceration in the brain, the hematoma, etc. You'll see it right away. However, the 6 secondary injuries do not develop until later. So they'll start developing up to from the time of the injury, meaning after the primary injury occurs, and they can develop as a result of that primary injury. Okay? We don't see that until later. So therefore, hence the restrictions as part of the concussion protocol. Because we're trying to see, is the patient stable or not, or are they developing any of the 6 secondary injuries? So first one is hypoxia and decreased blood flow. So these are now the secondary injuries. What will cause this? Well, the space occupying lesion in this particular example will be the hematoma, correct? Caused by the bleeding. So it will cause compression of arteries, veins, capillaries, which will impair blood flow to other parts of the brain. So this is a secondary injury. Therefore, this is a extension of the primary injury. So this will make the patient's prognosis worse. So the patient's problem isn't limited to the primary hemorrhagic stroke. So the patient will develop, this is, we'll consider this 2. So there's cerebral hypoxia and decreased blood flow. So the increased ICP here that results from this will possibly cause a seizure. So those are all consequence of hypoxia and decreased blood flow. Next is vasospasm. So this will be as part of the inflammation or irritation of the nerves from the primary injury. So there will be vasospasms, which can further decrease blood flow to parts of the brain. Third or fourth will be increased ICP. Now, increased ICP, we described this last week, correct? And we looked at signs and symptoms. We'll look at them again. So the manifestations, the other secondary injuries are the following. So it's mentioned here, so I'll just mention them now. So I already mentioned the hydrocephalus earlier. And then, so that's 4. 5 will be the herniation, brainstem herniation. And then finally, cerebral edema. Okay, so that will be number 6. Mannitol, I described mannitol last week, correct? Okay, so what is mannitol? It is a type of diuretic. Osmotic diuretic. Okay, works the same way as hypertonic saline. So how it works is it pulls water right here. Mannitol pulls water out of the brain by osmosis, hence what it's called osmotic diuresis, and then increases urinary output. That's why it's called a osmotic diuresis. So a very ideal for cerebral edema cases, such as what happens in stroke or in hemorrhagic stroke. Or also in any other case, like say you have a brain tumor or head injury or brain injury, same thing. Patients will benefit from osmotic diuresis. However, because this is a diuretic, what will it do to the blood pressure? And what did we learn last week and also today with those who went to simulation? What do we want the blood pressure to be with stroke or head injury? We want it to be high. So therefore, what should you do before you administer mannitol? Blood pressure must be high enough. Okay, so if the blood pressure is low, is it good to give this? No, because we want blood pressure in stroke and head injury patients to remain high. Remember CPP? We calculated it last week. Okay, so we want the CPP to be what? How much? 70 to 110. Okay, we want it to be between 70 to 110. Other interventions beside mannitol is the head of the bed elevation. So we described this last week, 30 to 45. 30 is the best. 45 would be your maximum. The benefit of this is besides, can you explain to me how does this decrease ICP? How does head of the bed elevation help with decreasing ICP? So what is it trying to prevent, or what does it facilitate? Flow to or from? Okay, so this promotes venous drainage from the head, because if you elevate it any higher, so let's say we go 50 and 60, so now you have an acute hip flexion, correct? So what will happen to intrathoracic pressure? Because now the abdominal contents will be pushed up the higher your head of the bed elevation, correct? Yeah. So therefore, what will happen to intrathoracic pressure if the abdominal contents push up against the diaphragm? It will increase. So therefore, what happens to venous return? It decreases and therefore increases ICP. So besides mannitol, so here's our hypertonic saline. The problem with hypertonic saline, and when it's usually chosen instead of mannitol, is it's a sugar. Well, it's 3% here. It's 3% NaCl. So the problem with this is what will happen to blood pressure? it will raise blood pressure because it will increase blood volume. Okay, unlike osmotic diuretic, wherein it will promote diuresis, right? This one does not. This will just increase blood volume with no corresponding, not very effective diuresis. However, this would be useful if the patient's blood pressure is low. Then your choice, instead of mannitol, we give hypertonic saline. And another phenomenon, which is not mentioned here, is the patients with head injury and stroke sometimes develop hyponatremia. We call that salt wasting syndrome. Hey, remember diabetes, SIADH? Okay, so the patients here can develop either, because as pressure in the head increase, ICP increases, will it cause pressure on the hypothalamus and the pituitary?
Yes.
Remember, one of the listed causes for both DI and SIADH, they were stroke and head injury or brain tumors. So therefore, those endocrine problems can develop in these patients as well. So those are part of the complications we have to watch out for. Hypertension. Again, so look at this in the case of hemorrhagic stroke. We're still under hemorrhagic stroke. So of course, we want our blood pressure to be what? Okay, read this for me. Guidelines. So is it any different from what we did for stroke last week?
Yeah. Because it was
But the point is, what do we want the blood pressure? Do we want it low or high? Okay, we want it high. We don't even want it normal. So the minimum is at least 140. So 140 or higher, that's good. But the limit again is 185, correct? I know it's hard. It's hard to do that, right? I mean, who wants their patient's blood pressure to be 180, right? 178. But in this particular instance, in head injury patients, stroke patients, doesn't matter, ischemic, hemorrhagic, we want the blood pressure to remain elevated.
Give a vasopressor to do that too.
To raise the blood pressure. We don't give that often, but yes, we can. Here's the labetalol. So some of you gave it today. So labetalol is it's an oral, so beta blocker, right? Okay, right. And then hydralazine is a vasodilating drug. You learn to give this often. You work in telemetry, you'll be giving hydralazine. So other interventions here to manage hypertension is, of course, to depress the sympathomimetic agents or actions like, for instance, straining, raises blood pressure, positioning again. We don't want the head of the bed too high because that will also drop blood pressure. So we don't want, that's another reason why we don't want to raise the head of the bed beyond 45 degrees. All right, so if it's hemorrhagic stroke, are we giving any anticoagulants?
No.
Alteplase, okay, so none. All right. So but these patients will eventually need one, right? But during the acute episode, so here the goal is to allow the brain to recover,
First, we have to stop.
but to also prevent complications such as bleeding. Yes. Okay. So when it's safe, then the patient will be started on anticoagulants. So now we have several options here. We can use heparin products or the oral novel anticoagulants. And then for here, we don't even wait for seizures to occur because yeah, we know they're gonna have seizures, so we give them. Okay, so the most frequently used drug is levetiracetam. Between these two, it's Keppra that's usually given over phenytoin.
Less.
And because this patient suffered trauma, correct? Is hemorrhagic stroke traumatic? Okay, so will it raise metabolic rate? Will it cause a fever? What did we say about fever last week? What is its effect on ICP? It increases it again. So fever must be treated because they will develop a fever. Okay, so make sure you control that. And this is the life-saving intervention. The patient will undergo surgery. Now, this will be similar. So whatever we cover on this section will be similar when we get to head injury in a little bit. So this is, if the patient is actively bleeding on the CAT scan, of course, we need emergency craniotomy in order to stop the bleeding, clip the bleeding arteries, burn them, cauterize them, and then evacuate the hematoma. Because otherwise we will have herniation. Okay, so we don't want any brainstem herniation. So this is the only way to, most effective way to control increased ICP and bleeding is to stop it through craniotomy. Now, there are two types of craniotomies. It's not in this chapter though, it's in 61. But let me show you the tentorium. On the skull, so there's a spiky section right above our ear at the level of the ears, which divides the, right here. So this is our ear here. And that's our nose. This is our eye level ear. So this is called the tentorium. So it's a spiky section, literally dividing the upper and the lower parts of the brain. Now, if the surgery of the craniotomy, so when the doctor opens up the skull above the tentorium, the position post-op must be head of the bed elevation, about 30 degrees. You can still turn them left or right, okay, because we don't want any pressure on injuries, right? But we will have to keep them at 30 to 45 degrees. If it's below the tentorium, meaning the incision, the skull is cut here below the ears, then the position post-op will be flat. Okay, you can still, if the patient has any difficulty breathing, you can do reverse Trendelenburg, but you cannot have any neck flexion. Are we clear? Okay, so the body must be flat. Is that clear? For which type of craniotomy? Okay, below. Yeah, so we just call them simply supra or infratentorial. So if the incision is supratentorial, which has 61. So if it's above the tentorium, supratentorial incision, then that means head of the bed, elevated 30 degrees. If it's infratentorial, head of bed must be flat. If any breathing problems occur, we can do reverse Trendelenburg. Okay. But the point is we don't want any neck flexion, right? If it's infratentorial.
When I used to hear about the thing that when they make the incision in the skull, they release air, but it's actually liquid, but it's not air pressure. So some of the CSF flows out when
yes, I'll get to the monitoring shortly, okay? Because we've been talking about intracranial pressure, but we really didn't see yet how to measure that. Okay. Okay. So here are other interventions. So this will be a combination now. We're gonna summarize all our interventions to manage intracranial pressure. So of course, this will involve frequent neurologic exams, a full exam, just like you did today. So pupillary assessments, neurovascular, sensory motor assessments, okay, and mental status. Okay, let's start with the environment. Okay, so we already understand 30 to 45 degrees. Another is you don't want them. So these patients will be placed on 300 milligrams of docusate sodium. The regular dose for stool softeners is 100 milligrams. So these patients will be on 300. Okay. Because we really don't want them doing any Valsalva maneuver. For sneezing, they will be given antihistamines. Lighting must be dim. Patients will have photophobia, most of them anyway. And because these are bed-bound patients, no getting out of bed, so they'll be on after the acute episode, of course. Okay, after the first 24 hours, they'll be placed on heparin or any other. If there's still a danger of bleeding, let's say we have other complications that result, then the patient will be placed on what is a non-pharmacologic way to prevent blood clots, DVTs?
Stockings.
The stockings or the
Ambulance.
antithrombic compression devices, right?
Yeah, but they can't ambulate, yeah.
Correct.
can.
And we can't, if we can't use heparin for whatever reason. This is not just for stroke, okay? So if your patient, you have patients in the hospital, consider all patients in the hospital as at risk for DVTs. So make sure the patient has something to prevent it. So if you don't see any heparin products or any other anticoagulants ordered, what is your responsibility? Ask for what? The compression devices, okay? You can put it on, but we need to get paid also. Okay, so the hospital has to get paid, right? So ask for an order, so it's ordered, and then the hospital can bill for the device, okay? We need to get paid.
What's the thing called the electronic one that
Which one?
after surgery they have the
Yes,
electric-
SCDs.
you press a button and it like inflates.
In place.
and
Yeah,
it's like
those
a
are
compression.
pneumatic,
Oh.
pneumatic compression devices or sequential compression devices.
That would apply with this.
Yeah. So these are all, they're also called antithrombic pumps, AT pumps, different names.
But they're helpful.
Yeah, they're life-saving devices. Very simple, but yet, yeah, we cut down on DVTs with those things. They just need to be put on. Okay, so sometimes they're ordered, they're never put on, we put them on the bed, they're never on the patient. So it's not true. Good thing you asked. So it's not true that the patient doesn't need it if they're in, if they're sitting in a chair. The point there is we want the blood flowing, correct? So that's why these things compress the leg, the calf muscles. So therefore, even if they're on a chair, but they're not walking,
So,
is circulation really promoted?
no.
No, so these things need to stay on. Okay, so it's not true that some nurses will say, "Oh, he's awake, don't put it on." No, yeah, there's awake, but they're not doing anything. What's the difference with them sleeping or awake, but they're laying in bed? Correct. Okay, so whenever they're not moving, keep it on. Okay. Seizures. What are seizure precautions? So we did this last semester. What are your interventions?
If they have seizure.
Suction and pads and what's oxygen and IV access. Very good, children. So here's the hydrocephalus. So watch for this. This will, of course, you can't see hydrocephalus, but you can see the behavior of the patient. So any signs of changes in mental status, that means ICP is increasing. Rebleeding can occur, meaning after you stopped, let's say after surgery, we stop the bleeding, they can bleed again. So that will be another stroke. So I mentioned this earlier, the salt wasting syndrome. We can't really explain unless they have SIADH, but we don't know why the patients with stroke or head injury experience hyponatremia. Okay, so that's what we call a syndrome. We can't really explain. Yes.
If they're experiencing hypernatremia, is it a possibility that they may show like a Tourette syndrome? Is that a possible thing that they may
What again? Possible.
It's a Tourette, don't just
So-
Tourette's or.
Just so the Shabbat.
Trusol,
No, that's hypocalcemia.
that's calcemia, yeah.
So for the danger of hyponatremia is what would happen to the brain cells? If the sodium level in the blood is low, via osmosis, what will happen? Osmosis.
Sodium and potassium.
They're gonna get.
Yeah, so water from the blood will actually enter the brain cells, causing cerebral edema, causing seizures. So therefore, is it dangerous?
Yeah.
Yeah, it's an emergency. Of course, if you have evidence of SIADH, besides hyponatremia, you have low urine output, and you also analyze the urine sample, which will be what will be the specific gravity of the urine in SIADH?
Low.
It's actually high,
Specifically.
right? Because they pee very little.
Oh, yeah, the one,
Correct.
but yeah.
So report that, okay, promptly. Remember, SIADH is an emergency.
Because they don't pee here.
Okay, so here's now our discharge. So this is for the hemorrhagic stroke patient. Please read on your own. That's it for hemorrhagic stroke.